All right, a very good evening to all of you. Good evening. So we are all here to make this day more productive for each one of us. Yes, and we're going to start with obs and gynae sessions, and I'm going to start with the gynecology session first. So I'm glad you're all here. I will try my best to make it as productive as possible. And here are some instructions for each one of you. I want you all to make notes in my session. Okay, this is something that I personally believe in very strongly, but the notes are going to be in the format in which I am writing, which means only in the form of points and keywords to approach questions. Okay, so you're going to make the notes exactly the way I am doing it for you in the class, right? Now, what I have seen is that, most of you students, aaj we have less number of sessions. We will be easily winding up by 9 o'clock. Okay, we would be easily winding up by 9 o'clock. Don't worry about that, right? Now listen to me very carefully. Now when I say that I'm going to start with my teaching, what I want you to know is that what I have seen is when I'm solving doubts for all of you, when I'm answering your queries, and when I'm putting my daily question series as well, what I have noticed is that all of you students know individual topics. Yes, so I know that you know adenomyosis, I know that you know fibroid. The problem that I see with each one of you is in application of that topic when it comes as a general question. Yes, so what I thought of doing today is, instead of teaching you individual topics, I want to teach you approach to clinical presentations. Yes, so because in your exam, which is what is the new pattern is going to be a clinical vignette. Here the question starts with a clinical presentation of a patient. So they're not going to tell you that this is a question on fibroid or this is a question on adenomyosis. Yes, so they are going to be on clinical presentations. So what I want you to do is, I'm going to teach you how to approach these MCQs which are based on clinical presentations, how to keep narrowing down, how to identify keywords, and how to pick them together, put them together, and reach to a diagnosis or investigation or next step. Yes, so on this note we will start off. Are you all ready? Sab taiyar hai? Yes, are we all ready? Okay, so you are going to write with me, and you're going to write in short, no sentences, only keywords. Please do not write sentences, just take down the keywords the way I am doing it for you. Okay, so let's do this. So your first clinical presentation that I'm going to do for all of you is going to be a lady who comes to us with abnormal uterine bleeding. Yes? So your first clinical presentation is a patient who comes to your OPD or emergency, right, with abnormal uterine bleeding. And I'm going to talk about abnormal uterine bleeding in the reproductive age group, right? Because post-menopausal bleeding is something that I want to take separately. So abnormal uterine bleeding in the reproductive age group, how should you approach this question? Because that's how it's going to start. A lady comes with this kind of bleeding. So the first thing I want you all to remember is, whenever a lady or in the question comes with abnormal uterine bleeding, the first rule of thumb is you have to rule out pregnancy. Okay, no matter what rest of the question is, pregnancy has to be ruled out. Okay, it has to be ruled out. Then your next thing that you will try and identify in this clinical question is going to be the age of the patient. So rule out pregnancy in every woman, whether she is an 18-year-old girl or she is a 45-year-old woman, right? So rule out pregnancy. The next thing is, see the age. It gives you a little hint. It's not a mandatory thing, but it will give you hint towards what you have to think. So age. If the age is more than 35 years, okay? So if the age is more than 35 years and she has abnormal bleeding, you should think of conditions like fibroid uterus, okay? You should think the question could be on adenomyosis. You should think the question could be on a polyp. And you should think the question could be on endometrial hyperplasia or endometrial cancer. Okay? Can you please check your local connection, because here the audio is coming out to be fine. Can you please check your local connection once? Yes, because here the audio is coming out to be absolutely fine. Okay? Satish and Rajat, check your local connection, please. Check your local connection. The audio seems to be fine here. Okay? Okay, so think of endometrial hyperplasia, think of endometrial cancer, and think of anovulatory cycles. Okay, so think of anovulatory cycles. So this is if the patient's age is more than 35 years of age. Okay, if she is less than 35 years of age, okay, if she is less than 35 years of age, think more in terms of endocrinopathies. Okay, think in terms of PCOS. Okay, so polycystic ovarian syndrome. Think about endometriosis. Okay, think about coagulopathy. And think about pelvic inflammatory disease. And think about again anovulatory bleeding. I will tell you why anovulatory we have kept in both the columns, because remember, anovulatory bleeding is something that you see in extremes of age. Yes, so you can see anovulatory bleeding in a young girl who's adolescent age, and you could see anovulatory bleeding in someone who is perimenopausal as well. Right? So that is why I have kept it in both the columns. So this helps you in keeping, what things are more likely to happen if she is more than 35 and less than 35. But this is not diagnostic. You have to club it with other key factors or keywords. What is the next keyword we are going to look at? The next keyword in the question you will look at is, what kind of abnormal bleeding are they writing? If the question says heavy menstrual bleeding, okay, so if the question says what kind of abnormal bleeding, this is the third hint that you will look at, heavy menstrual bleeding. Then you are going to think more in terms of fibroid uterus. So that gives you a hint. It could also be endometriosis, but less often. I will tell you what is the more common presentation of endometriosis. And it could be a coagulopathy, especially if it is a young girl, right? So if it is a young girl, it could be a coagulopathy. Yes? So if they say heavy menstrual bleeding, you think of this. But if they write it as intermenstrual bleeding, which means she is having normal menstrual cycles, and in between the normal cycles, there is bleeding as well. Okay, so if the word written in what type of abnormal bleeding is intermenstrual, you have to think of number 1, polyp. That's how an endometrial polyp presents. You should think of hyperplasia or malignancy, and both these you know that the age will be more, right? So think of polyp, think of hyperplasia, think of malignancy here. Then it could also be infections like cervicitis, yes, or a cervical ectropion, right? So cervicitis or a cervical ectropion and an infection in the uterus. So endometritis, okay? And last, I am writing, it could also be a presentation of a woman with PID, but that's not the main presentation. And that is why PID goes more lower in the list. So don't start thinking of PID if the main complaint is intermenstrual bleeding. I will tell you when to think of PID as the first possibility. So I am keeping it in the order of importance. And it could also be someone who is on oral contraceptive pills. Yes, they can have intermenstrual bleeding, but those are less likely to be the reasons in your exam, so they go at the bottom of the list, right? Third third type of abnormal bleeding that they could comment on is that your patient has irregular bleeding. So how is irregular bleeding different from intermenstrual? So intermenstrual, we said, what is intermenstrual? Normal cycles, but in between she will have bleeding. What is irregular? Irregular is she may have a period of amenorrhea followed by bleeding. Yes, so she will have a period of amenorrhea followed by bleeding. This period of amenorrhea could be 35 days, it could be 40 days, it could be 45 days, it could be longer than that. And it is variable. Sometimes it will be 40 days, sometimes it is 60 days. So that is what is when I say irregular bleeding. So now tell me, what would be at the top of your differential if it is a 30-year-old woman with irregular bleeding for last 2-3 years? What do you think it is going to be? Then we are going to think of polycystic ovarian syndrome. Okay, that is going to be polycystic ovarian syndrome, and any other cause which leads to anovulatory bleeding. Okay, so any other cause that leads to anovulatory bleeding, for example, derangements of thyroid and prolactin can cause anovulation. Yes, and if they cause anovulation, they will cause irregular bleeding. Very good. Yes, so this is the next important thing. So first was age, right? Second, I said is, see what kind of bleeding are they saying. Now, once you know these three things, look at for other words that will help you in making a diagnosis. For example, yes, for example, in the history, okay, if they say your patient has obesity and hirsutism and irregular bleeding, you know that it is going towards PCOS. Yes. In the history, if they say your patient also has galactorrhea or a visual field defect, it goes in favor of a prolactin abnormality. Yes. So those would be again the key words. So for PCOS, obesity, hirsutism, acanthosis nigricans. Yes, those would be keywords for PCOS, right? Okay. When I say hyperplasia or malignancy, what do you think would be the keywords there? Hyperplasia or malignancy, what do you think would be the keywords? For hyperplasia and malignancy, look for risk factors of cancers. And that is where we integrate different topics. Please remember, you must all know the risk factors of endometrial cancer. It is repeatedly an MCQ. So again, if you talk about obesity, early menarche, late menopause, PCOS, you all know that these are risk factors for endometrial cancer. So they will club intermenstrual bleeding. In the history, there would be risk factors for the malignancy. Yes? Tell me quickly, what would be the keywords for cervicitis? Cervicitis, discharge. Yes? Maybe the question says on a speculum examination, you will see a discharge, or you see a locally inflamed cervix or some local factors, right? So those are the risk factors when we talk about cervicitis, or even when we talk about endometritis. So again, endometritis will have a presentation similar to PID. Tell me, what would be the keywords in the history that will make you think that the cause of abnormal bleeding is infection, right? Again, it's likely to be a discharge. It is likely to be a lower abdominal pain. Yes, it is likely to be tenderness. Yes, so discharge, lower abdominal pain, tenderness, these all go in favor of a pelvic inflammatory disease, which can also have endometritis. Yes, so you have to link all keywords together. एक कीवर्ड से आंसर नहीं बनता है. You have to learn to integrate different topics into one. Okay, that's how it goes. Then, what do you think would be, yes, a new onset of a sexual activity? I will tell you more about PID as I go further. So new sexual activity. Yes. So these are going to be features which tell you about an infection, right? Then what would they write in the history if they have to talk about fibroid? So if they have to talk about fibroid, it's generally a painless heavy menstrual bleeding. But the thing here would be an enlarged uterus. I would come to that in the next step. Endometriosis. What would they write for endometriosis? A relatively younger girl with dyspareunia, dysmenorrhea. Yes? These would be the keywords that make you think towards endometriosis. Right? What about coagulopathy? What about coagulopathy? Coagulopathy, as I said, it's going to be a young adolescent girl. And apart from young adolescent girl, there may be history of bruising. So easy bruising, gingival bleeding, yes. So these are going to be your connecting dots with the type of type of abnormal uterine bleeding. Now, once we have looked for the type of abnormal bleeding and the age, what is the next thing we look for? The next thing I want you all to look for is PSPV findings in the MCQ. Okay? PSPV findings in the MCQ. Yes? Now, please understand, a cervical ectropion, a cervical polyp, or a local growth, right? So on pars speculum, what all can you already make a diagnosis of? A cervical polyp, yes, ectropion, which is an E version of the epithelium, yes. You can also see a growth. If it's a malignancy, you will be seeing a growth there, yes. And these are the things that you can actually see in the PS examination itself. What else? Discharge. Yes, discharge on the cervix goes in favor of infective process, right? PV. The most important thing in the PV exam, what they give you in the clinical question is what? Uterus size. So if the uterus is enlarged, yes, tell me, if the uterus is enlarged and a lady has abnormal bleeding, what does your diagnosis restrict on to? So now this is more likely to be a fibroid uterus. Yes, so this is more likely to be a fibroid uterus. What else? Adenomyosis. Right? Adenomyosis. What else? It could be malignancy. And it could be a hematometra. Yes? So if the uterus is enlarged, you will think about fibroids, adenomyosis, malignancy, and hematometra. Keywords which will further help you. This is a irregularly enlarged uterus. So fibroid is irregularly enlarged. Adenomyosis is symmetrically enlarged. You all know it's a globular uterus. Globular. Fibroid is non-tender. Adenomyosis is a tender uterus, right? Malignancy, again, it's enlarged, but usually the enlargement is because of growth in the cavity. So here, it's actually a growth in the cavity. It is again non-tender, right? Non-tender. Hematometra, a symmetrical enlargement. Okay? And what would be the key word with hematometra? Cyclical pain. This could be because of cervical stenosis. So maybe the lady has cervical stenosis. So these are how you're going to link the keywords with the possible cause. Okay? What if the uterus is normal size? So uterus is normal size and your patient has abnormal bleeding. What can it be? Very important. An endometrial polyp. Okay? Remember, endometrial polyp, the uterus is absolutely normal in size. It is a non-tender uterus. Okay? Endometritis. Normal, but this is going to be a tender uterus because there is an inflammatory response there. Yes? So tender uterus and endometritis. Endometriosis. Again, it's a normal uterus, it's a non-tender uterus. The uterus is non-tender, okay? But, keyword, retroverted uterus and fixed uterus. Those are the keywords because there are adhesions there. So retroverted fixed uterus with adhesions. Okay, so this is what is, your keywords that will help you link to the diagnosis. Now, once you've already learned these things, let's look at what they ask you, what would you do next? So you have to think of all this to know what would you do next. So as I said, always the first thing is to rule out pregnancy. Yes? What is the first thing? Rule out pregnancy. So for people who joined late, rule out pregnancy. What do you do next? So let's say she is non-pregnant. What do you do next? For abnormal bleeding, ultrasound. TVS, you're going to do a transvaginal ultrasound which will confirm your findings most of the times, whether it is a fibroid, whether it is a polyp, whether it is adenomyosis. Yes? So please remember the same keywords will apply. Fibroid, it will be an irregularly enlarged uterus. Adenomyosis is a symmetrically enlarged uterus. Polyp, you would see a growth, but there are certain keywords. Please remember with polyp, they will mention a feeder vessel sign. Right? Polyp has a feeder vessel sign. On the other hand, adenomyosis will have Venetian blind. Those are the keywords. A heterogeneous myometrium. Those are the keywords. Right? A polyp is seen in the cavity. Yes, it's seen in the cavity. Ultrasound again are fibroids. On the ultrasound are hypoechoic. Yes, the uterus itself is non-tender, bache. It is the pouch of Douglas which is tender in endometriosis. Okay, it is the POD that is tender. It is the adnexa that can be tender. The uterus is non-tender, bache. Okay, in endometriosis. So fibroid is going to be hypoechoic, and those are the keywords that you should know. Now, what is the next thing you should do? Please remember, if your patient is more than or equal to 45 years of age, okay, if your patient is more than or equal to 45 years of age, irrespective of ultrasound findings, okay, irrespective of ultrasound findings, what should you do? Do endometrial sampling. So how they confuse you is, they will already give you the ultrasound findings and then try and confuse you. So if your patient is more than 45 years, irrespective of ultrasound findings, endometrial sampling has to be done. And this has to be a OPD procedure first, which is called as an endometrial biopsy or a EAC, endometrial aspiration cytology. Right? So either by these two methods, do an endometrial sampling. Yes? But let's presume that your patient is less than 45 years. Right? Then, if she has high risk factor for endometrial cancer, okay? So if she has high risk factor for endometrial cancer, you know what are those? HNPCC, Cowden syndrome, PCOS, granulosa cell tumor, and obesity. Then again needs endometrial sampling. It needs endometrial sampling. Now listen to me very carefully. The third most confusing question is, if ultrasound shows a focal growth, right? Example, maybe ultrasound is suggestive of polyp. Maybe ultrasound is suggestive of a malignancy inside. So if ultrasound is showing a focal growth and they are asking you next step, Don't mark endometrial biopsy. Don't mark endometrial biopsy. Go and mark hysteroscopy. Okay? Go and mark hysteroscopy. For focal lesion, hysteroscopy. You can do a sampling also, you can see also, you can remove also. Right? And last scenario. Ultrasound shows nothing significant. This is the most confusing scenario. Ultrasound shows nothing significant. Patient not responding to routine treatment. What is routine treatment? OCPs. Generally for abnormal bleeding, we will give OCPs. So if ultrasound shows nothing significant, no fibroid, no polyp, no malignancy, nothing, and patient is not responding to routine treatment, then again she needs hysteroscopy. Right? So then again she needs hysteroscopy. So those are your approach based questions for a patient with abnormal bleeding. Okay, so with this we finished the first topic, that was approach to abnormal uterine bleeding. I hope you have taken down the key things. The next thing, let's look at the next clinical presentation. So the next clinical presentation which I feel all students get confused with is acute pelvic pain. Okay, so next is, if there is an MCQ on acute pelvic pain, you do not know how to answer it. Yes? Yes. Focal growth, hysteroscopy. You will take a hysteroscopic guided biopsy. No blind biopsies. Okay? Punch biopsy is not for the uterus, Divya. That is for cervix, beta. Okay. Let's go on to acute pelvic pain. Whenever there is a question on acute pelvic pain, an acute pelvic pain in gynae is not acute, means not right now. It can be any time in 3 months. So acute pelvic pain, okay, what should you think of? You should again think of either it could be ectopic pregnancy, it could be a ruptured ovarian cyst, okay, ruptured ovarian cyst. It could be what? Ovarian torsion. It could be a TOA. What is TOA? Tubo-ovarian abscess. Okay? It could be a tubo-ovarian abscess. And it could be PID. So an MCQ which comes out to be on acute pelvic pain, ectopic, ruptured cyst, ovarian torsion, TOA and PID. Now quickly listen to me. The first thing is, what was the kind of onset of pain? Although the word here is acute, but please remember, as far as PID and abscess is concerned, these are insidious. Okay? Do you understand the meaning of insidious? They will happen over a period of 2-3 days. But when you talk about ovarian torsion or a ruptured ovarian cyst, this is abrupt pain. Okay? It is going to be abrupt pain. For people confusing with endometrial thickness, you never do endometrial thickness in reproductive age. Endometrial thickness only has value in post-menopausal women. So don't do that mistake. It's a gross mistake. Okay? Ectopic is generally insidious, but can be abrupt if it is what? Ruptured ectopic. Yes? It can be abrupt if it is ruptured ectopic. So first thing is, let's see the kind of pain they have mentioned. The second keyword, was there any event preceding the pain? Okay, for example, what would be the keywords? If your patient says she has a new sexual partner or a new sexual activity, think about PID. Similarly, TOA, always, tubo-ovarian abscess is in the background of PID. So the inciting events are similar. So new sexual activity, multiple partners, young girls, okay? Think of this. Ovarian torsion. This girl will already have a history of a large ovarian mass. Somewhere in the history, they will give you this hint that probably she already is a known case of a large ovarian mass. Ruptured cyst, intercourse. Okay, the pain was, after an episode of intercourse or a vigorous activity. Yes, so both ovarian torsion and ruptured cyst can happen after vigorous activity. Right? And ectopic, the most important thing is a history of missed period. Yes, a history of missed period. Okay, those are the key relating events. The nature of pain. Okay, please remember, because whenever you talk about rupture, it is going to be a severe pain, abrupt and severe. Torsion, abrupt and severe. They are severe pains. Whereas when you talk about abscess, PID, ectopic, they tend to be more mild to moderate pains. Okay? Right? So, the girl will say she had pain for 2 to 3 days. Yes? And now she is presenting to you. So, these are more milder forms of pain. Then, very important keyword in the MCQ which will help you think of what the question is talking about. Look at history of fever beta. Agar fever hai, so I have only 2 DDs, torsion and abscess. The difference is that in torsion it will be low grade fever. Right? So in torsion it will be a low grade fever. Whereas when you talk about abscess, it is a high grade fever. Right? Whereas in other 3 conditions, when it is ectopic or it is, a ruptured cyst or PID, fever is absent. So if the MCQ says fever, you have only 2 possible DDs, abscess or a torsion. Okay, and then you look at the grade. Right? Then always in the keywords, try and look for the side of pain. This is super important. The moment they say the pain is bilateral, okay? The moment they say the pain is bilateral, think of PID, okay? Think of PID. The other pains are unilateral. They are towards the side of the pathology. But if a woman is complaining of pain on both the sides or there is tenderness on both the sides, then it is more likely to be PID. That's a very, very key word. It will help you clinch the diagnosis. The same holds true with tenderness in the pelvis. PID will have usually tenderness on both sides. On PV exam, okay? So it will have tenderness on both sides. But when it is an abscess or it is a torsion or it is a ruptured cyst, tenderness on PV is more localized, right? So it is going to be a localized tenderness for all others. So I'm writing LT, okay? Localized tenderness for all others on the site. Mass. On a PV exam, there could be a mass, but mass in sub mein ho sakta hai. So that will not help you clinch the diagnosis. The only place where mass is absent, it is PID, right? So on a PV exam, mass is absent, okay? In PID, it can be present in all others. Not necessary, but can be present. Okay, so ectopic can be present, right? A ruptured cyst, it can be present. Similarly, an ovarian torsion or an abscess, it is definitely present. So definitely present in an abscess and torsion, can be present in ectopic and a ruptured ovarian cyst, right? So those are important things. Lab investigations will definitely help you. ल्यूकोसाइटोसिस सिर्फ एक में है और वो है एब्सेस एंड इट विल बी सिग्निफिकेंट Okay, it will be significant leukocytosis in the abscess, right? With ovarian torsion, it could be borderline normal values because it is reactionary. Torsion की वजह से एक reaction होता है जिसकी वजह से fever होता है, borderline normal values हो सकते हैं, right? So in all others, generally there is no leukocytosis. So if classically they are writing a TLC count of 15,000, 18,000, please go towards abscess. Okay, go towards abscess. So these are some very, very important keywords that will help you pick up what is the question likely talking about. Now, once you have gathered this information from the clinical vignette or long stem, what should you do as far as investigation goes? Rule of thumb. First investigation, again, rule out pregnancy. Remember, it can be a pregnancy related pain. Always first rule out pregnancy. Okay? Right? Then, once you've ruled out pregnancy, investigation of choice would be again ultrasound. Okay? Investigation of choice is ultrasound. This will surely help you to pick up what it is. For example, if it is ectopic, on ultrasound you can see a complex adnexal mass with increased vascularity. Okay, a complex adnexal mass, increased vascularity. Most importantly, ovaries will be seen separately. मास अलग से दिख रहा होगा, ओवरी अलग से दिख रही होगी, राइट? सो कॉम्प्लेक्स मास विद इंक्रीज्ड वैस्कुलैरिटी, ovary seen separately is ectopic. Now, ruptured cyst. What would you see? You may see again a adnexal mass. You will see an adnexal mass. But what would be helping you to clinch a diagnosis? Batao. Large amount of fluid in the pelvis. It's not small fluid amount. Large amount of fluid in the pouch of Douglas. Yes, and very importantly, this fluid can have debris. It's not physiological fluid, it is blood, right? Or it may have inflammatory cells, so it will have debris, okay? So it's not clear fluid, it's blood, okay? Most of the times, if you have made a diagnosis of ruptured cyst, although it says ruptured, don't worry about it. Majority of times patient के vitals are stable, right? So majority of times the patient's vitals are stable and the management of even a ruptured cyst is observation and serial ultrasound. But if you have made a diagnosis of ruptured cyst and she has unstable vitals, then you need to operate. Laparoscopy is what we prefer generally, but if it is unstable vitals, it will be laparotomy, right? So this is ruptured cyst and what they could ask you. Okay, if it is an ovarian torsion, what would be the findings on ultrasound? Very, very important. They will clinch the diagnosis. It will be a round enlarged ovary. Okay, it will be a round enlarged ovary. It will be heterogeneous in appearance, which means at some places the blood flow has stopped, so it will not appear symmetrical. It will have a heterogeneous appearance. Ovary may be anterior to uterus, but the key thing, if they write, and they will make it the question easier if they write this, they will write on Doppler, okay, on Doppler, whirlpool sign, whirlpool sign. If they have given this, then it is ovarian torsion. Yes, Doppler mein what else could they write? Impaired venous return, okay. Impaired venous return, keywords, they will help you pick up the diagnosis, right? Management, operate, it's an emergency. and the management is detorsion, not oophorectomy. Okay, it is detorsion. Oophorectomy only done when it is a grossly non-viable ovary. So if ovary non-viable, then yes, oophorectomy. But otherwise, the general answer should be detorsion. Okay, it should be detorsion. Lastly, if it's an abscess, right? If it's an abscess, the ultrasound, the first thing I've always tell you, abscess is always in the background of PID. तो question में PID का background होगा सारा pain, right? Discharge, cervical motion tenderness, adnexal tenderness, ठीक है? Then you will see a complex multilocular mass. But the most important thing here, ovary not seen separately. Key thing. In the ultrasound they will say ovary नहीं नजर आ रही, सिर्फ एक mass नजर आ रहा है. So complex multilocular mass, and again because it is abscess, it is not clear fluid. Yes, it will be fluid with internal echoes, debris. Yes, there is pus inside. So it will not be clear fluid in the cyst. It will be fluid with internal echoes. There is pus inside. Right? So this is very important. And most of the times it's a tubo-ovarian abscess. So they use a word which is called as retort-shaped. Tube and ovary together make a shape which is called as retort-shaped. Right? Now, majority of times these patients are stable. Vitals are stable in TOA. And majority of times the management is antibiotics. Right? So, IV inpatient antibiotics. Admit करना है, घर नहीं भेजना. Right? But please remember, if the patient has unstable vitals, and they say abscess is bigger than 7 centimeter, right? Then you go and operate. Do a incision and drainage. Yes? So if vitals are unstable, right? If it is more than 7 centimeters or not responding to antibiotics. Yes, then you think of operating and doing a PID. Please remember, PID is very simple. I've given you all the key things. Bilateral pain, new sexual activity, right? Yes, cervical motion tenderness, adnexal tenderness, tenderness is also usually bilateral, right? Then this is what is PID. The management you all know is antibiotics. Yes, management is antibiotics. Lastly, something physiological and they may give to confuse you is Mittelschmerz. Okay, Mittelschmerz. Please remember, this is mid-cycle. Okay, it is not once a time, it is a recurrent mid-cycle pain. She will have it every month. It is always unilateral, and it only lasts for few hours. It's not something that will go on for weeks and days, right? So, mid-cycle, recurrent pain, which means happens with every cycle, unilateral, lasts for few hours and then apne aap goes away. That is what is Mittelschmerz, ovulatory pain. Right? So this was the second clinical presentation, which is pelvic pain. Okay, pelvic pain. If it is ectopic, you have to treat it like ectopic. I can't teach you entire management of ectopic pregnancy. Is this clear? Red degeneration, यहाँ का DD नहीं है. That is a pregnant patient. Chili potato, I like your name. You make me feel hungry. Okay, chili potato, red degeneration will be in pregnancy. यहाँ मैंने बोला pregnancy is ruled out. Then we are talking about DDs, bache. No gross mistakes, chili potato. Okay. Third clinical presentation where I feel students get confused. What is the third clinical presentation? And that one becomes easier if you have done first two. And that is adnexal mass. Bacche confused. Adnexal mass ka kya kare? Right? So first, always remember adnexal mass again. Rule out pregnancy. I don't want to leave this out because you make gross mistakes. So first, see whether she is pregnant or non-pregnant. If she is non-pregnant patient, what is the next thing that you look at? No, internal echo is not always abscess and above. It can be blood, right? Blood and debris, okay? Like you see in endometrioma, like you see in an hemorrhagic cyst. Yes? Pus, also internal echos, but these will be inflammatory cells. So they give a different echogenicity, okay? Now if she is a non-pregnant patient, look at the first thing is the age of the patient, right? Look at the age of the patient. Extremes of age, which means adolescent girls or young girls and old women. Take this to be what? Malignancy. Take this adnexal mass to be malignancy. With adolescent girls, these are germ cell tumors, right? Whereas with older women, these are epithelial ovarian tumors. Perimenopausal. If she is perimenopausal, think of sex cord, granulosa cell. But before you think of diagnosis, I said think of a malignant mass. What features are you going to see on ultrasound? So always please remember, investigation of choice for adnexal mass is ultrasound. Adnexal mass is any mass coming from the tube or ovary or the connective tissue around it, right? So if the ultrasound is using words like thick septae, solid component, papillary projection, increased vascularity in the septae. Okay, so thick septae, solid components, papillary projections, increased vascularity in the septae, and if it is bigger than 10 centimeters, these findings on ultrasound tell you it is a malignant mass. Then think of DD in terms of age. Young girl, germ cell tumors. Older women, epithelial tumors. Perimenopausal, granulosa cell tumors. In the same question, if it is a malignant mass, in the stem of the question, look for risk factors of malignancy. So that is why I am saying you have to know the risk factors of endometrial cancer, ovarian cancer. They are your hints, right? So in the stem of clinical vignette, look for risk factors of malignancy. Now, let's say the mass is benign, which means it does not have these high-risk features. If it is a benign mass, use or see keywords which will help you tell you what mass it is. For example, if it is a mass with vaginal discharge, if it is a mass in young girls, think about tubo-ovarian abscess. I told you, fever. Think about tubo-ovarian abscess. If there is history of PID and now there is a mass and infertility, yes, think about hydrosalpinx. Yes, so benign mass with discharge, fever, she's a young girl, think of PID and tubo-ovarian abscess. But no fever, old history of PID, now coming to you with infertility, think of hydrosalpinx. Then, if the mass looks benign, right? And the woman is pregnant, right? She will have bleeding, right? So these women also have a presentation of bleeding. Think of what masses? Think of corpus luteum. Think of theca lutein cyst. Think of even what? A dermoid. Yes? So, the clinical history could be that of bleeding. Yes? Think of corpus luteum. Think of theca lutein cyst in pregnancy. Think of dermoid in pregnancy. Keywords in the ultrasound that tell you it's dermoid. If you see hair, if you see Rokitansky protuberance, if you see tip of iceberg, if you see a fat fluid level, yes, and yes, this is where you think of red degeneration. Okay? But it's not an adnexal mass, it's a uterine mass. So this woman will have history of fibroid. It's a uterine, it's uterus, it's not an adnexal mass. Okay? So this woman who will have history of fibroid and coming to you with pain now, not adnexal mass, they come with pain, acute abdomen. मगर क्योंकि तुम बार बार पूछ रहे हो red degeneration, I have to write it down. Okay? Then benign mass, right? Benign mass and infertility. Benign mass, infertility. One I told you, think of hydro. What else? Think of endometriosis. What are the keywords? What are the keywords in the MCQ? Keywords will be the same. Dysmenorrhea, dyspareunia. Very, very important. In the clinical history, they may give you tender nodules on uterosacral ligaments. Right? So, tender nodules on uterosacral ligaments. Tender pouch of Douglas. These are all things that go in favor of endometriosis. And what is the mass you are talking about? Chocolate cyst. Remember, this is also going to have internal echos. So how do you differentiate internal echos of chocolate cyst and internal echos of an abscess? Chocolate cyst के internal echos homogeneous होते हैं. They are evenly spread. In an abscess, the internal echos will be heterogeneous, present somewhere, somewhere they will not be present, जहाँ पे pus collection होगा. Right? So this is going to be a homogeneous internal echos. All over inside the mass, you will see these internal echos. Right? So homogeneous internal echos is what is the internal echo of a chocolate cyst. Remember, the mass can be physiological. Right? So the mass can be physiological. And what is this? It can be a follicular cyst. Yes, it can be a follicular cyst. Remember, generally it is asymptomatic. Okay, so reproductive age woman, asymptomatic cyst, it is a unilocular cyst, clear or anechoic, and usually has no pain. Sometimes it can have mild pain. Sometimes it can have mild pain. Management of follicular cyst is only observation and serial ultrasound. Okay, so observation and serial ultrasound if it is a follicular cyst. So actually adnexal mass तब आएगा जब pain और bleeding वाला algorithm आता होगा, because these things will usually coexist in an MCQ. Yes. Now next. something which is very, very likely again, and we have done it a lot of times in the class, but I will quickly repeat it because I know it is a very, very probable question, is a question on vaginal discharge. हाइड्रोसैल्पिंग्स का कोई ट्रीटमेंट नहीं होता है. IVF, infertility due to hydrosalpingosis, IVF. And remember, very importantly, before you do IVF, you have to do a salpingectomy. Otherwise, IVF will not be successful because hydrosalpinx fluid is toxic to the baby. ATT only if it is tubercular. You don't give ATT to every hydrosalpinx. Okay? Now, vaginal discharge. सबसे पहले, what is physiological discharge so that you understand when to look for pathological. Please remember the physiological discharge is white or colorless. Right? It is mucoid, transparent, and it can be thick or thin depending on the cycle. Yes, so it can be thick, it can be thin depending on the cycle. So this is what is the physiological discharge. Pathological, you all know, it can be bacterial vaginosis, it can be trichomonas, it can be candida. The first thing is color of the discharge in the MCQ, but that alone should not be why you are answering the question. Combine it with other keywords. So, bacterial vaginosis, color is off-white, grey, right? Trichomonas, green, can be yellow, right? What about candida? You all know it is curdy white, right? Please remember, bacterial vaginosis can never be yellow. It's never a yellow discharge, okay? Then, the second keyword for trichomonas is it's a frothy discharge. Frothy, agar frothy likh diya, think of trichomonas. Then, bacterial vaginosis is classically a foul smelling discharge. Trichomonas is also foul smelling, but candida is odorless. Okay, so candida is odorless, right? Next keyword is vaginal pH. pH more than 4.5 is what you see in bacterial vaginosis and trichomonas. For candida, it is less than 4.5. Local examination, there is no signs of inflammation in bacterial vaginosis, whereas signs of inflammation can be present in trichomonas and candida, right? Very important again is pruritus. Generally, no pruritus in what? In bacterial vaginosis. It is present in candida and in trichomonas, but in candida, it is the main symptom. So, if the most troublesome thing is pruritus and not the discharge, then think of candida. If the main symptom is discharge and not the pruritus, think of trichomonas. Okay? So, pruritus. Also remember, the discharge is copious in bacterial vaginosis and in trichomonas, whereas it is a scanty discharge in candida. The discharge is less. The main complaint is pruritus. There are no urinary symptoms, okay, if it's bacterial vaginosis, whereas urinary symptoms are present, right, in other two. Remember, if they use the keyword as splash dysuria, burning in the local area or vulva after urination is splash dysuria. That's what is candida. If they write strawberry, cervix, vagina, then think of trichomonas. That's the key thing on local examination. Yes? Now, please remember, the investigation of choice for vaginitis or vaginal discharge is saline microscopy. Okay, it is saline microscopy. if you see clue cells, which are nothing but epithelial cells, right? They are studded with bacteria, but they will not write cells studded with bacteria. They will write cells with irregular border. Okay, cells with irregular border. You will see the motile trichomonad on saline microscopy, and you will see what in Candida? Pseudohyphae. Yes, you will see pseudohyphae in Candida. Very important, and I'm sure you will not make a mistake. Bacterial vaginosis is not an STD. Trichomonas is an STD. Candida again is not an STD. Please, bacterial vaginosis is not an STD, but it is seen in sexually active women. Some of you say, ma'am, MCQ में sexually active लिखा था, इसलिए bacterial vaginosis नहीं हो सकता. No, it is not an STD, but it is seen in sexually active women, right? So don't confuse this. And on the basis of this, treatment of partner not done. Yes, whereas treatment of partner is done in trichomonas and it is not done in Candida. In Candida, you will do treatment of partner only if partner is symptomatic. Sometimes it can be transferred sexually. Okay. Then, one more confuser which I see, whiff test is strongly positive in bacterial vaginosis, but it can be positive in trichomonas as well, while it is negative in Candida. Whiff test is when you add 10% KOH, you get a fishy odor. So in the MCQ, whenever we write fishy odor, a mean odor, think of bacterial vaginosis. Okay, think of bacterial vaginosis. Drug of choice, metronidazole, both non-pregnant and pregnant for both trichomonas and bacterial vaginosis. Okay, and it is fluconazole for Candida. It is fluconazole for Candida. Please remember, pregnant, non-pregnant, the drug of choice is metronidazole. Another one that you can give in bacterial vaginosis is clindamycin. You can also give clindamycin, but the drug of choice, the single best answer should be metronidazole. Right? So this was on vaginal discharge. Again, a very, very potential question for all upcoming exams. Next. The next topic that I feel you students are always confused and are answering incorrectly is fibroid and only the management part. I seem, whenever I see so many students land up doing mistakes, only management and in short. Please remember, if the main symptom of your patient is heavy menstrual bleeding and she has a fibroid, okay, so heavy menstrual bleeding and she has a fibroid, right, please remember, and she has a submucosal fibroid. Okay, so heavy menstrual bleeding, she has a submucosal fibroid. The management is hysteroscopic myomectomy. Remember, hysteroscopic myomectomy is done only for type 0 and type 1 fibroid. Okay, doses and everything have been given in your routine class, Prerna. This is not a routine class, beta. Go and open your class notes. Okay, so type 0 and type 1 is for hysteroscopic myomectomy. Heavy menstrual bleeding and she has other types of fibroid, which means intramural or subserosal, right? Then please remember, the first line treatment is OCPs. Okay, the first line treatment for other types of fibroids is OCPs. It can also be an LNG IUD. It can also be only progesterone, right? And it can also be Tranexa. But drug of choice is OCPs. All these can also be used. Please understand, this is the algorithm when family is complete. I will tell you what you are supposed to do if the woman desires pregnancy. So this is once the family is complete, okay? If there is no response to first line treatment, okay, the second line is either GnRH, agonist or antagonist. It could also be uterine artery embolization. It could be after this, it could be HIFU or ablation, endometrial ablation. So the first line is OCPs, no response, GnRH agonist or uterine artery embolization, no response, HIFU or ablation, and finally no response, myomectomy or hysterectomy. Right? So I repeat, this is when the family is complete. The management of the fibroid with heavy bleeding will depend on the type of fibroid. If it is submucosal, do a hysteroscopic myomectomy. Submucosal may be type 0 and 1. Other types of fibroid, the first line is OCPs, then go to GnRH agonist in UAE, then go to HIFU and ablation, then go to myomectomy. Second, family complete and main problem is pressure, right? So bulk symptoms or pain symptoms, right? Family complete and the main problem due to the fibroid is bulk, which means pressure symptoms or pain. Then what do? Then here the first line treatment becomes either uterine artery embolization or GnRH agonist and antagonist or a HIFU. No OCPs, no Mirena, no progesterone, no Tranexa. Those drugs don't help in bulk and pain symptoms. Okay? If there is no response to this, go ahead and do a myomectomy or hysterectomy. We don't give steroids for fibroids. Okay? Third, desiring pregnancy, very important. Your patient desires pregnancy and she has a fibroid. सारे बच्चे confused, क्या करना है? No confusion. She desires pregnancy and she has a fibroid and the fibroid is submucosal. Do a hysteroscopic myomectomy. But, which means even if the fibroid is asymptomatic, it's not causing bleeding, it's not causing pain. But if she has submucosal, you do a hysteroscopic myomectomy, provided or first rule out other causes of infertility. Right? So before you go and operate on her, just rule out other causes of infertility. Yes? So this is for submucosal fibroids only. Other fibroids and asymptomatic. Other fibroids and asymptomatic but desire pregnancy. Expectant management. So if it is a subserosal or an intramural fibroid, asymptomatic and she desires pregnancy, expectant management. Expectant management means follow up with serial ultrasound. Follow up with serial ultrasound. Yes? Last thing, एक्सपेक्टेंट मैनेजमेंट किसमें करना है? सो एक तो मैंने बता दिया, इफ शी डिजायर्स प्रेगनेंसी, डज नॉट have submucosal but has intramural or subserosal fibroids that are asymptomatic, then expectant. In which other condition would you do expectant management? If she is asymptomatic and fibroid or uterine size is less than 12 weeks. Okay? So, asymptomatic and uterine size is less than 12 weeks. Then you do an expectant management. The third indication for expectant management is perimenopausal women. Any size uterus, right? So, perimenopausal women, any size uterus, and especially if it is asymptomatic. Right, you can do a expectant management. Yes, if she has some symptoms, for example bleeding, then you start with the routine management of heavy bleeding itself. Is it clear? Is it clear? Pregnancy, do not touch the fibroid. Okay, expectant management in pregnancy as well. No touch technique to the fibroid in pregnancy. Right, is it clear everyone? Right. So those are some of the key things that you should know as far as fibroid and management are concerned. Very potential question in all exams. Next. The next algorithm is going to be for abnormal pap smear. Very easy, but I see students get confused. So this is going to be very quick, right? So this is going to be very quick. L-sil and patient is less than 25 years of age. Repeat pap smear at 1 year. Okay, so repeat pap smear at 1 year. L-sil and more than 25 years. Colpo biopsy. Okay. Ascus and less than 25 years, repeat paps at 1 year. Okay, ascus and more than 25 years, HPV test, which is called as a reflex test. So HPV test, which is called as a reflex test. All right. Then if HPV turns out to be positive, okay, if HPV turns out to be positive, do a colpo biopsy. Okay, do a colpo biopsy. Right. If she has ASC and H, okay, ASC and H, whenever you see the word H, you definitely have to do a colpo biopsy. You should add ECC also, endocervical curettage. Okay, you should add endocervical curettage as well if it is ASCH. All right. Then HCIL. Whenever it is H, irrespective of age, do a colpo biopsy and endocervical curettage. Yes, do a colpo biopsy and endocervical curettage. If it is AGUS, atypical glandular cells, yes, so if it is atypical glandular cells, do colpo biopsy, do endocervical curettage and add endometrial sampling, especially if the patient is more than 35 years of age. So if it is glandular cells, atypical, colpo biopsy, endocervical curettage and endometrial sampling if the patient is more than 35 years of age. Is that clear? This is for abnormal pap smear. Just adding, patient comes with post-coital bleeding. Post-coital bleeding. What should you do? If they ask you next step, it has to be a per speculum examination and a pap smear. Right? So per speculum examination and paps. But if on per speculum exam you see a growth, then you take a punch biopsy, not paps. So if you see a growth, take a punch biopsy. If your patient has persistent post-coital bleeding, right, which means persisting for more than 6 months, do colpo biopsy even if paps is normal. Yes, so persistent post-coital bleeding, which means for more than 6 months, do colpo biopsy even if paps is normal. Is it clear, everyone? Yes? Alright, so this is the algorithm for management of abnormal pap smear. I don't want any student now to make a mistake on this. Always an MCQ in most of the exams. Right? Now, next algorithm, I'll just take a few more minutes, right, and try and wind it up quickly. Post-menopausal bleeding. It is there in the AIMS capsule. You can see it from there, but I will just try and do it here so that you don't do it wrong in the exams. Please remember the first investigation is TVS, transvaginal ultrasound. Okay. If ET is more than or equal to 4 mm, do what? Endometrial sampling, which should be a OPD procedure first, which means you will do either an endometrial biopsy or you will do a EAC, endometrial aspiration cytology. But if TVS shows a focal growth, okay, if TVS, be very careful. If the transvaginal ultrasound is showing a focal growth, don't mark biopsy and DAC, mark hysteroscopy. Okay, mark hysteroscopy. It would be hysteroscopic directed biopsy if there is a focal growth. Yes, then please understand this. If the report is atypical hyperplasia, and listen to me very carefully, if the endometrial biopsy report is atypical hyperplasia, right? Before you treat, you have to confirm now. Because the moment MCQ says atypical, it is very dangerous. So confirm. So when they ask you next step now, so she came with post-coital bleeding, you did a biopsy, it's atypical hyperplasia, what do you do next? Confirm. How? By doing a OT procedure. D and C with hysteroscopy. OT based sampling, D and C with hysteroscopy, dilatation and curettage with hysteroscopy. Once you have confirmed, then after confirmation, remember, treatment of choice is always after confirmation. So after confirmation, if it is atypical hyperplasia, you do a hysterectomy with BSO because your patient is post-menopausal, right? So after confirmation, do hysteroscopy and BSO, right? This is post-menopausal. If it is atypical hyperplasia pre-menopausal, only hysterectomy, yes? And if hyperplasia is without atypia, then you all know You don't need to do an OT procedure. So endobiopsy shows hyperplasia without atypia. No need to do an OT procedure. Straight away treat with progesterone. The preferred progesterone is Mirena. The preferred progesterone is Mirena, and do repeat sampling at 6 months. Right? Do a repeat sampling at 6 months. Right? So this is if the report turns out to be hyperplasia with or without atypia. Okay? Then quickly, the next algorithm is if the question is on infertility. Although the pelvic mass covers everything, but still, if the question is on infertility, how to approach? Okay? How to approach? If your MCQ says words like obesity, words like hirsutism, words like irregular cycles, right? What should you think of? What should you think of? Think of polycystic ovarian syndrome as the cause of infertility. Yes? If your MCQ also mentions weight changes, sudden weight loss, sudden weight gain, galactorrhea, or it comments upon vision, visual field defects, think about endocrinopathy. It could be prolactin or a thyroid disorder. Yes? So they also can present with infertility. Then, if the question is on infertility and the keywords are dyspareunia, dysmenorrhea, adnexal mass, tender POD, uterosacral nodules, I have already talked about these. Then what do you think of? Yes, very good. You think about endometriosis. Yes, then you think about endometriosis. If the question is on infertility and the keywords are vaginal dryness, hot flashes, inability to sleep at night, think about premature ovarian failure. Yes, then you should think about premature ovarian failure, right? So that's how you should lead. Finally, if there is infertility and the keyword is suggestive of PID, discharge, adnexal tenderness, adnexal mass, I'm not going to repeat the history, or history of tuberculosis, evening rise fever, weight loss, doughy abdomen. Yes, so evening fever, weight loss, doughy abdomen, right? Think of tubal factors infertility. Then think of tubal factor infertility. Now, very quickly, the most important part, once you've made a diagnosis, what will you do for your infertility? So please remember, if it is PCOS, the drug of choice is letrozole. But the first thing that you do is weight loss. If the patient is obese. So in PCOS, the management will be first weight loss, then if no response, letrozole. If it is a disorder of prolactin or thyroid, you treat the respective disorder. Usually it is hyperprolactinemia and it is hypothyroidism. So treat these disorders. Endometriosis and infertility. Because of the night sweats, sulfapyridine, the night sweats are typically, or hot flashes are typically more at night. So patient complains of sleepless nights. Okay. Endometriosis. If this is the cause of infertility, if the endometriosis is mild or minimal. So minimal and mild endometriosis, the treatment is clomiphene citrate and IUI for 3 cycles. If no response, IVF. But if it is moderate to severe endometriosis and infertility, then straight away IVF. Premature ovarian failure. Yes. Confirm कैसे करते हैं? FSH levels more than or equal to 40 is diagnostic. FSH more than or equal to 20 is suggestive. Serum E2 will be low in these patients. Yes. And if they are infertile, what would you do for them? You will do a donor ovum plus IVF. Don't write clomiphene citrate here. No induction. Donor ovum and IVF. If it is tubal factor infertility and it is severe tubal factor infertility, by severe we mean what? Anatomical distortion. So hydrosalpinx, bilateral distal block. Yes. So if there is a what? Anatomical distortion and there is a bilateral distal block, it is a severe tubal factor infertility. The treatment of choice is IVF. Yes, the cause can be anything. It can be PID, it can be TB. But if it is severe infertility, do IVF. Is it clear? So this is the approach for infertility. That brings me to the last, because some people have been asking, although it is very much there in AIMS capsule, but this will be the last algorithm for all of you, and that is going to be on primary amenorrhea. Okay, so yes, first doubt, should you rule out pregnancy? Yes. So some of you think, ma'am, why she is saying primary amenorrhea? Girls can lie, okay? They may not give you the correct history. So even in primary amenorrhea, please rule out pregnancy, especially if secondary sexual characters are present. You all will otherwise make gross mistake, not in exams but in clinics. So always rule out pregnancy. Okay, so always rule out pregnancy. Now, please remember the first thing that you have to do after ruling out pregnancy. So I'll write second rather than first. Second, the first is rule out pregnancy. Second, what do? Second is you need to do a physical examination. Yes, so you need to do a physical examination. Okay. Look for breast development. Look for height in the MCQ and look at local vaginal examination. Why? This will tell you a lot of things. Yes? So, do a physical exam. Now, once you are done with physical exam, the next thing to be done is what? Ultrasound. Okay? The next thing is to be done is ultrasound and FSH levels. Right? So, these are the two most important lab investigations. Ultrasound and FSH levels. Right? So, now, ultrasound mein uterus is present. FSH is high. Right? What do you think this is going to be? Uterus is present, FSH is high. Gonadal dysgenesis. Okay? Gonadal dysgenesis. Please remember there could be other hints. Your other hints in the MCQ will be what? Short height, breast absent. Right? So short height, breast absent. Right? So this is when you should think of gonadal dysgenesis. Second, uterus present FSH low. Okay, uterus present FSH low. Low means anywhere between 1 to 3 international units. Yes. Please remember, this can be Kallman's syndrome. Yes, it could also be a physiologic delay. Yes, and this could also be pregnancy. So in pregnancy, the FSH levels turn out to be suppressed. They are very low levels, right? So uterus present, but obviously early pregnancy may not be picked up on an ultrasound, right? So do a serum testing when in doubt, serum HCG, all right? So Kallman's हो सकता है, physiologic delay हो सकता है, pregnancy हो सकता है, right? And what you need to know is, with Kallman's, what would be the hint? With hint will be anosmia. Yes, the hint is going to be anosmia. Physiologic delay is a diagnosis of exclusion. When you cannot make any other diagnosis, then you think of physiologic delay. Pregnancy में क्या होगा? You will have HCG positive. So always do HCG. Okay, always do HCG. Gonadal dysgenesis में आगे क्या करते हैं? Confirm करने के लिए karyotype. Please remember, ultrasound will also show you whether the ovaries are present or not. Yes, so in gonadal dysgenesis, very important, the gonads are absent, right? There are streak gonads. Whereas in Kallman syndrome, in physiologic delay, in pregnancy, gonads will be present. Yes, gonads will be present. Okay, so now uterus is absent. So if uterus is absent, right? Okay, first uterus present, एक और रह गया. Uterus present, FSH normal. Yes, uterus present, FSH normal can be what? Imperforate hymen. Yes, this can be imperforate hymen. Key things. Ultrasound will show you hematocolpos, hematometra, which means maybe enlarged uterus. Yes, maybe an enlarged uterus. But the most important things for you, local examination will show you a bulging membrane. Bulging membrane. Now your difficulty, madam, what if it is transverse vaginal septum? Please remember, the presentation is exactly like imperforate hymen. Yes. So in transverse septum also, the uterus is present, FSH is normal, there can be a hematometra and a hematocolpus. But here, local examination, no bulge. Why? Septum is thick, fibrotic. It will not bulge because of blood behind it. Yes, so no bulge will be seen. Cough impulse will be present in imperforate hymen. Cough impulse will be absent in imperforate hymen, in transverse vaginal septum. Also remember, transverse vaginal septum thoda ऊपर होता है, upper 1/3. So will you be able to see or feel some part of vagina? Yes. Vagina can be seen. Whereas in imperforate hymen, there is an obstruction. You cannot see any part of vagina. The opening is blocked. Yes? The third thing, which can be a DD to this, is vaginal agenesis. Again, uterus can be present, FSH can be normal. But what is the finding here? On local examination, no vaginal opening. कोई opening ही नहीं है. There is no introitus. Whereas In imperforate hymen, there is an opening. In transverse septum, there is a vaginal opening. In vaginal agenesis, there is no opening itself. Yes? So these are DDs of each other. FSH values which are less than 10 international units is what is considered as normal. But values between 1 to 3 are low normal, suppressed levels. Okay? Now, coming to condition when the uterus is absent, and then we will switch over to unulcer. Okay? So, now, uterus absent can be either Mullerian agenesis or androgen insensitivity syndrome. Okay, so it can be Mullerian agenesis or androgen insensitivity syndrome. Right? Keywords. Mullerian agenesis, pubarch is present. So axillary hair, pubic hair, they are present. Whereas in AIS, the axillary hair, pubic hair are absent, but please remember they can be sparse, but they can never be normal. So if they write pubic and axillary hair are normal, think of Mullerian agenesis, right? Then the other keywords. In AIS, the patient can have inguinal hernia. Okay, inguinal hernia. In AIS, the patient can have a short, blind vagina. Whereas in Mullerian agenesis, usually there is vaginal agenesis. So there is absent vagina. Right? And very, very important, testosterone levels. Right? Testosterone levels are higher in AIS, whereas testosterone levels are going to be normal female levels in Mullerian agenesis. In both of them, whether it is Mullerian agenesis or AIS, breast development is present. So it will not help you to differentiate the two. So breast development is present in both. It will not help you in differentiation. To differentiate, see what I have written. Okay. Finally, to confirm, it has to be a karyotype. So you should all remember in AIS, it is 46XY, whereas in Mullerian agenesis, it is 46XX. So karyotype will help you confirm. Also, ultrasound will also show you what? Ovaries. It is ovaries in Mullerian agenesis and it is testes in AIS, but this is undescended testes. And therefore, patients of AIS must undergo gonadectomy. Remember, no gonadectomy in Mullerian agenesis. Gonadectomy in AIS after puberty. Yes? So, this is going to be it from my side. I have already gone a little overboard and people are going to kill me for it. Okay? So, female levels should be less than 70 nanograms per deciliter. Okay? It should be less than 70 nanograms per deciliter. No, we are not doing prolapse here. Please remember, this is must-know topics. Okay? It has to be things which have the highest probability to know their keywords, to put them together, to learn the approach, yes, in clinical vignettes, and to arrive at next step or diagnosis or treatment. Right? So, this is going to be from my side. If you want to see, you can add this with AIMS capsule and DBT where we have covered mind maps and other things as well, right? But this is supposed to be the most concise and high yielding things which have the highest probability of being asked in your exams, right? So otherwise we've done quite detail in the classes. Please go back, right? For each of these things, if you have any doubt, go back and be very thorough in these topics. Okay? So thank you so much. It was a pleasure here, and I hope I have made it effective for you, and I hope I have made the concepts clear and your algorithmic approach clear. Okay? I will hand over now to Dr. Anil Meechandani. He will be taking the obstetrics session for you. Thank you so much for bearing with me. All the very best. फोड़कर आना. Gynae obs में सारे question ठीक होने चाहिए. It's a very important subject for your exams. Rock it. Okay? God bless you all, and may you all come out with flying colors. Remember, you are special, you're very capable, and you're all going to do exceedingly well. Just have faith and persist. Okay? God bless you. Thank you. Bye-bye.